Okay, this is the second time I've followed a preacher. Never again. uh, it's, I mean, it's really hard. Um, I was very moved by Reverend Freeman's talk, and quick anecdote. When my late father had to go into hospital, rural upstate New York, not where Bev was living, but in another corner of the state. There were two hospitals, a general hospital and a Catholic hospital. My late father was a very religious Orthodox Jew. He insisted on going to the Catholic hospital. So why? Why, Dad? Why do you want to go to that hospital instead of the only on general where, the doctors are? I said, well, you never know. So he was hedging his bets. So anyway, that's not what I'm. Anyway, I have two disclosures. One disclosure is that I have no disclosures financial. I'm waiting for someone to offer me enough money to do something that I have something to disclose. But the real disclosure is, that was not in my bio, that I was the family caregiver for my late husband for 17 years. He had a traumatic brain injury, which left him quadriplegic and with a severe cognitive impairment. And I cared for him at home for 17 years. He died in 2007. And so when I was listening to Bev and listening to Diane and listening to the others, I could feel the anger welling up in me as to all of the things that happened in that period, which I have tended to put away, but I can get them when I need them. And this happened, this started 20 years ago. But honestly, I'm not sure that things have improved all that much. Although the fact that everybody today mentioned families was really good. The sense that when I was first starting was family, I was the wife, as if, the wife will do it, the wife will take care of that. I lost some people go to the hospital and they lose their dentures and their eyeglasses. I lost my identity. I became the wife. Not that that's a bad thing that I was, but that was not all I was. So that colors what I'm going to talk to you today. And it really is, but it's not just my personal experience. It's been informed by 20 years in the field. And I've worked in medical ethics even before that. So let me see how this works. Um, It doesn't work. Where do I press this to, which one is it? Oh, it's this way. There we go. Okay. I use the IOM definition to start here about health literacy. Um, it's hard to get to a health literate standard that, everyone would agree we should all be at. Um, and I'm going to talk more about the health systems environment, not so much about the medical. We've heard a lot about the prognosis and all of the treatment decisions. This is more about how do you navigate the healthcare system. It's constantly changing. It changes day by day, and it's becoming more complex. Even as people try to simplify things, it's getting more complex. So the person who is health literate needs to understand not only the medical situation and what the treatment might be and how to make those choices, but also understand bureaucratic language, insurance language, institutional arrangements. So it's another whole area that has to be built into being health literate. And I would say that um, from my perspective and my experience, health literacy is not just a problem of poor people or of people with low educational levels or of any particular group of people. In certain situations, we are all health illiterate. And it's impossible to be totally uh, up to date and understand everything. Um, a woman in my office, I work in a health services research organization. We have meetings, and this was not my meeting. A woman who was there for another meeting came to my door and said, "Can I ask you a personal question?" okay, what is it? She came in, she runs a ambulatory clinic. She's not a physician, she's the administrator. She runs an ambulatory clinic in the city. She said, what's the difference between hospice and palliative care? Okay, I went through the best I could, but here's a person who is in the healthcare system and she didn't know. So we have to assume that at some point, every one of us needs more information and explanations. And it's not just at the sixth grade level, it can be at any level. Um, so understanding services may be harder than understanding basic health information, I think. Okay. Um, Here's what I expected from the healthcare system when I started my journey. I expected it to be a maze. I knew that it wasn't going to be simple to take my husband home because I knew there was nothing there to support him. In fact, the nurses and the social worker waved goodbye to me from the rehab facility and said, you're on your own now, dear. And I was. But I figured I'm pretty smart, got through a lot of things in my life. I can do this. But here's what caregiver actually experiences, what I experienced. It's impossible. You know, if you could follow the yellow brick, if you could find the yellow brick road, then you could follow it. It's really complex, and there aren't a lot of people around who actually know. They may know their little piece of how to get you through the hospital experience, but then in the community, they don't know that, or in the community, they don't have any idea what the hospital situation is like. So there are some reasons I think that palliative care is particularly hard to understand, and that's part of the organizational system. It's hard to spell. It's hard to pronounce. I've heard at least 3 different pronunciations here this morning. There's this confusion between hospice and palliative care, and even professionals don't share the same definition. Palliative care doctors have one, specialty, and I was listening to somebody the other day calling it PalMed. So what is that? Oh, that's palliative care. Home care nurses, not palliative care nurses in a hospital setting, said, well, that's what we do all the time. We do that. You know, it's nothing special. We just take care of sick people. Long-term care staff, they think they're doing palliative care when they keep the resident quiet and maybe comfortable, but they're not doing palliative care either, but that's their definition of it. So if the providers have different definitions, how can the patient and the family caregiver understand it? So and this I think is a point that hasn't been made yet. Before you learn new information about palliative care, you have to unlearn misinformation, and that is all over the place. Palliative care is just for dying. Palliative care is just to save the government money. Palliative care means giving up hope. I think we heard that this morning. Pain drugs lead to addiction. You didn't hear that, but we hear that a lot. Or you have to be in a hospital to get palliative care. Insurance won't cover palliative care at home. That may or may not be true, but it's a barrier. And this is a really important one. We heard a little bit. Palliative care means the doctor, whatever that doctor might be. It might have been the oncologist. It might have been a primary care doctor. It might have been a geriatrician. That doctor with whom you've struggled to get a good relationship is abandoning the patient and the family. So before you start talking about palliative care, you have to recognize that people already come to this with certain beliefs that have been, in the air, sort of. They're like the urban legends or the rural legends or the whatever, but they do believe these things. So I think from the family caregiver perspective, there's special challenges. It's intensely emotional. And rather than, as we've heard some clinicians try to sidestep that, I think you have to confront it directly. And I think often that's all that's needed, is saying, I understand this is difficult emotional time for you, and you're going through a lot. It's not something that can be put aside. It's part of the experience. And as a family caregiver, you're making healthcare decisions with a person or for the person. So it's not what you want, it's what this person would have wanted, said they wanted, now wants. And I think that's very difficult. It's a difficult role to play. Um, we've heard some of this conflict or different levels of understanding with the family. I had to laugh when two people mentioned the daughter from California. When I talk in California, it's always the daughter from New York who comes and messes things up. We had a plan in place, and the daughter from New York came, and so it's always the daughter, right? The daughter gets blamed. I don't know why. I don't think that's fair. But it's definitely true that there are people within a family who each perceive they have an equal role to play and have an equal share in this decision making, come to it from very different perspectives and information. And if they haven't been brought along the process, they really are at different points of understanding. Feeling excluded from the healthcare team, that's a very powerful feeling of caregivers. When my husband was in rehab, I tried for the 4 or 5 months he was there to get a meeting with the healthcare team. I know they had them because they would come to me and say, now this is what you're supposed to do next. But they never let me come to a meeting, even though I really pushed for that. Now that may change, but that wasn't the case then. Concern about affordability, it's a real thing. I don't know why someone said this morning didn't matter because poor people didn't have the money. And as Medicaid changes to Medicaid managed long-term care, it's going to matter even to very poor people on Medicaid because their plan may not cover some of the things that maybe they want. Concern about being able to provide complex care at home. Palliative care, as it is practiced today, isn't, chicken soup and a pillow. It can be very complicated, and we heard about the morphine drip and so forth. So families are concerned about that, and rightly so, and they're not getting training. I had focus groups on another project this week, and I heard about 2 people who were sent home to care for a patient with a PICC line, centrally inserted a catheter without training. How do you do that? How is that acceptable? Family caregivers do want information, and this is our United Hospital Fund Next Step in Care Guide to Hospice and Palliative Care. It's the most frequently downloaded guide in English and Spanish, and in some months, it's more downloaded in Spanish than in English. So make that of what you will. It's available in Chinese and Russian. It's free. And it suggests to us that people are not getting the information they really want because they're finding it on our website. There's a comparison, but you can look at that. Using a caregiver assessment as a guide to discussion, I think it's been alluded to, but just calling it a caregiver assessment makes it seem a little more medical formal. Acknowledge that there's a lot to learn about this palliative care, how it will affect the patient, learn about the caregiver situation, who does what for the patient, what are the caregiver's other responsibilities, probe worries and concerns. On our assessment, which is called What Do I Need as a Family Caregiver, the most revealing question is, what worries you the most? And the question and the things range from, can I get home in time to pick up my kid, to can I take my mother home, can I take care of her, to why has God done this to me, to someone from whose parent was in the Holocaust saying, we lived through that, why is this happening? And they range from totally mundane to really existential. So it's a revealing question. And probing the worries and concerns is always essential. So these have been stated, you can see them, I think involving the family caregiver at every stage. So nothing comes as a big surprise. No surprises. If you could go through one of these really bad experiences and say, but I knew that was kind of going to be happening and I knew what to expect. To offer support and training, remember to dispel the myths and use a simple definition of palliative care. This is another approach to effective communication from Rich Frankel, who's in Indianapolis, that we've found very helpful when working with providers. To invest in the beginning, develop the trust, Elicit the patient's family caregiver's perspective. Listen, listen, listen. Demonstrate empathy, and that's in words and in body language. No looking at the watch, no going like this. Invest in the end to summarize what you've heard and what the next step will be. They're common sense, but often not implemented. So thank you very much, and you can look at our website and see the different guides we have. Thank you.